Laura Cunningham with Retreat Behavioral Health, and I am Zooming in today. Thank you for inviting me.
Welcome. Who is next? How about right under Laura? Can you please introduce yourself?
They don't know where they are. That's Bill.
Oh, sorry.
That's Bill.
Oh, Bill.
Hello, this is Bill Rowland. I'm Program Director of Lehigh Valley Hospital School Counseling Center.
Welcome, Bill. Next, we have Rosemary. Rosemary. We need you to unmute yourself, Rosemary. Oh. Okay, we can get back to Rosemary. How about Amy? Can you please introduce yourself and where you're from?
Hi, it's Amy Smith from Lehigh Valley Health Network. I'm a medical educator and I work with our select medical students.
Welcome. Thanks for coming. And then to the back. Oh, okay. So Rosemary's having trouble with audio. That happens, right? Sometime we'll have someone help you out with that. Shall we go around?
Sure. Hi, everyone. My name is Yamelisa Taveras. I'm the Project Director of Counseling Solutions of the Lehigh Valley and Drug and Alcohol Counseling.
Hi, my name is Chris Stewart. I'm with the Neighborhood Health Centers of Lehigh Valley. I'm a community nurse.
I'm Jasmine Irizarry, and I am from Neighborhood Health Centers. I work with medication treatment and ECHO.
And I'm Abby Letcher. I'm a family doctor at Neighborhood Health Centers and one of the prescribers in our MAT program, and it's good to have you all back. And welcome, Laura. Okay, so today our presentation is about some co-occurring disorders. Gonna try and share here. Come on. Anybody know how to get it off of this view and onto the regular view? So that it doesn't look like that.
Yeah. I tried last time and I didn't know.
Okay. Nope, that's not it.
I'll play with that.
Okay, so we're having a little bit of a I don't know how to do this thing of I don't know how to get it to look just like the slideshow on the share screen. So bear with seeing what's coming next. I'm sorry about that. The folks who developed this presentation for the HRSA ECHO come from New Mexico and the University of Washington. Appreciate their input on these slides. One of the things that they mention in their slides is there's too much to go over here in one presentation. I took out a few slides, but we'll see how we do. One of the presenters has a fair amount of funding that was reported as potential conflict of interest. I don't have any conflicts of interest to share here. And we're going to start just talking about hepatitis C. I'm sure you've all seen people with Hep C. There's a lot to talk about here. Mainly that the options have changed, but our responses frequently haven't. So, so we'll think about some brainstorming together of what can we do to improve access to Hep C screening and treatment in our population. So I may ask for some input, as you all know. Let's go. No problem.
See you when you're done.
Okay. So we'll be looking at a few slides about the public health of hepatitis C. And I think one of the things to notice is that over the course of the last 15 plus years, while other nationally notifiable infectious conditions, including HIV, AIDS, TB, and so on, had been going down over the decade between 2003 and 2013. So real triumphs of public health, and Hep C was a notable exception. So you can see that the deaths from Hep C were on the rise and actually crossed over all other nationally notifiable infectious conditions around about 2011, 2012, so that more people were dying of Hep C than of all other reportable conditions combined. I know you've probably seen some patients who are struggling with Hep C and who died from Hep C. This is unpleasant and takes a great toll on the community as a whole. When we look at just the prevalence, not death, but who has hepatitis C, one of our large surveillance studies is the NHCLV. They come out regularly, and they reported 3.6 million chronically infected and 2.7 with active hepatitis C. But take note that there are lots of people that don't participate in the NHCLV, people who are incarcerated, people who are hospitalized or homeless, people who are in a variety of different kind of institutional settings and Indian reservations. So a whole lot more people there who are also infected. And just take a look at that prevalence in the population who's incarcerated. That's a lot of people there. We also know that hepatitis C has a great impact on a particular age group. Shout out to our GWEP sponsors, the Geriatric Workforce Enhancement Program. Big spike in prevalence, that means who's got it based on year of birth. And it's folks who are my age and a little older. So in their older 50s and 60s, very high prevalence of hepatitis C. So that now it's recommended to have screening for everybody that's born in 1965, my year, or before. The acute hepatitis C cases, whoops, sorry about that. We saw a nice dip in the early part of the century here, 2000 to 2010, and then some steady rise, and that rise has continued. One of the scary things about hepatitis C is that most people who have hepatitis C don't really know about it. The acute phase where people are really sick and get jaundiced is actually not that common, even though we saw that it was on the rise. It's not how hepatitis C usually happens, maybe more of just a little feeling like a viral infection. So in that NHCLV survey, again, the one that excluding some of our higher risk populations, half of the people who turned out to test positive for hepatitis C had no awareness of that infection. Half of them did, and that's an opportunity. But when we look at other populations in some other surveys, it's up to 70, 80% who don't know that they have an infection. Why do we want to know about infections? We want to know about infections because now there are really effective treatments for hepatitis C. Folks who have been out there for a long time know that in the 15, 20 years ago, our treatments for hepatitis C were not particularly effective. It was hard to figure out who had hepatitis C. Way back in the day, it was non-A, non-B. But our treatments with interferon made people really sick. Many people couldn't finish the treatment because they had such severe side effects. And even when they did finish the treatment, it was not particularly effective. So you can see down in the little gray zone of this graph that even when people completed their treatment, 16% effective, 34% effective, not really much more than half the time did you get a sustained viral load reduction. Nowadays, our treatments, and also note, 12 months of treatment, 6 months of treatment, 12 months of treatment, and still no sustained viral suppression. Nowadays, the treatments that we have, 12 weeks, more than 90% effective, and that's multiple different regimens that we have available to us. They cost a lot. They still cost a lot, but we can get a good effect with relatively few side effects in 12 weeks. That's considered a permanent cure. So if we can screen people and identify who would benefit from treatment, we can cure this disease. And cure is better than I think any of us had ever expected. That cure doesn't just mean that we can halt the progression of the disease, it means we can reverse the progression of the disease. So nice dramatic picture there, but we can reduce the likelihood of liver cancer, cut in half the all-cause mortality, and reverse liver failure, which is amazing. And yet, we still don't do it. So you can see in this cascade of care. There's our large purple bar way on the left is the number of people in millions who are infected with chronic hepatitis C. People who are identified by NHANES shows us a little bit more of a picture of the prevalence out there, but people who get tested on their own outside of a study like that, much less. People who then, even though they're tested positive, get referred to care. There's a step off there too. People who get referred to care and actually go to get treated, big step off there. And then there's another smaller step off now, which is wonderful, of who actually gets treated and achieves that suppression in their viral load. Imagine if those step-offs were smaller, what that would look like in our community. So what are some of the things that get in the way? And I'd be curious from you guys out there, what are some of the things that have gotten in the way for the patients that you see? Treatment, particularly for this PWID, is people who inject drugs. That treatment of HCV or hepatitis has been really limited. We hear people talk about stigma. They show up someplace and they say, no, you can't get treated because you're injecting. That people are hearing that the drug use is an exclusion for treatment. Lots of people are incarcerated, and we have some concern for reinfection with HCV. What else are you guys hearing about why people don't get treated for hepatitis C or don't get tested for hepatitis C? Transportation. So Rosemary is suggesting that stigma is a big deal, but also transportation, getting places. That's for sure true.
A lot of people that I've spoken to, even when they were looking to start the treatment, they would say that either their insurance was giving them issues or that they weren't sick enough. Like they were literally coming back when I was working at Keenan House. They would come back from the clinic and they're like, yeah, my levels are not bad enough to receive the treatment. Mm-hmm. And from what I heard last, so that's shifting. Yeah, like that's changed, which is amazing. But I know that one of the big issues is like, what are they waiting for? You know, half of my liver to. So that was one of the big things.
Mm-hmm. What's your perspective?
This isn't specific to those who are injecting drugs, but as a whole, I think a lot of people don't go into treatment because they just don't feel sick. Like they don't notice it. So it's almost as if they don't think that it's that much of an issue because they aren't seeing any physical symptoms.
Right. So if we think about hierarchy of needs, maybe hepatitis C isn't right there on the top of the list. And when people know half a dozen or more of their friends that have died of an overdose, they're not thinking about their hepatitis C. So that definitely happens too. Bill, you guys screen. Do you have any thoughts about how many of your folks do you get into treatment? Do you have a secret sauce for us to share, or some other woe to share?
I really don't. Just, as you were talking, I was thinking about just the increase in numbers of individuals coming in for treatment that are positive for Hep C. And it is interesting, and kind of what you talked about before. It's like some of them, when they're talking about it, it's just accept it, and they'll say, hey, yeah, I'm Hep C. But you know, when we look at the severity of it, I don't sense that some of them, because of their other issues that they're arriving with and their other primary substances, they almost just seem to accept that as just the cost of their injection drug use. And don't look to necessarily get that treated initially, or there's not a history of having it treated before they get here.
Right. Well, and the first time that I was hearing this particular lecture, they were talking about the exclusion that people have faced, that they go, and this was happening for us at that time too, that you go to the Hepatitis Care Center and they say you need 6 months, 6 months clean. We could help them with some different language, but 6 months not injecting drugs. And the specialist that was providing this lecture at that time said, but we know that the people who are actively using are the ones who are most likely to be spreading this infection. So as a public health approach, those are the folks you would most want to get into treatment. And you can get them into treatment and cure. They may get reinfected, that's possible. But you can cure it and prevent spread to other people from that individual. So from a public health point of view, that's exactly who you would go to. And yet it's exactly who we don't. A couple of the things that have been shifting is some acceptance of that among the specialist population, so that they are starting to consider who to treat, possibly some shifts in who the insurance companies are approving for the medication. I'm not really aware, and if anybody else is, please feel free to share what sort of policy shifts have led to some of those changes.
Right now in Pennsylvania, you don't have to, what Melissa was referring to is you have to have a certain, what they call like fibrosis score. So you have to have a certain, you have to be on a certain place of the continuum when it comes to hepatitis C right now, and that can pretty much be 0. So you just have to have hepatitis C in order for, and an active viral load in order to be approved for treatment. Also for Medicaid insurances, in Pennsylvania, I'm not sure about the other states just yet, but at least in Pennsylvania, they are allowing primary care providers to treat it. Some of them require some consultation with a specialist, but that consultation doesn't have to be like in person. It can just be over the phone, or just have someone available just in case you have questions, just to be able to say that if you needed someone as a specialist, you'd be able to have that. So they are putting down some barriers in order to open up the possibility for treatment. So
right. And interestingly, probably one of the real driving forces to get states and insurance companies to look at allowing primary care clinicians to get involved in hepatitis C treatment is Project ECHO. So Project ECHO in New Mexico has lots and lots of data about supporting primary care clinicians to treat hepatitis C. And that they have as good or better outcomes as the specialists because of decreased barriers to care. Some of what Rosemary was mentioning, you know, if you're already coming for your treatment for your opiate use disorder or for other chronic conditions, that having that one-stop shop to get your hepatitis C treatment may be improving access for lots of people. So our good news is that at neighborhood health centers, we're going to start treating hepatitis C for our patients. I think our first patient is starting soon.
Yeah, we just submitted prior authorization, everything like that. So as long as that's approved, we're getting started.
So we'll keep you updated. Are any of the rest of you seeing any primary care treatment of hepatitis C out where you're at?
It's very limited in terms of the number of providers that will see patients and will treat patients. We do have a couple of specialists in the area that will.
Okay. How about you, Laura? Anybody out there that's working on decreasing barriers?
Yeah, I would love to have our Director of Nursing, Melissa Callahan, give you updates. It's definitely a lot along the lines of what Bill was reporting. Hello, Bill. I know we're set to meet up soon. We have a great relationship back and forth with our patients coming out of treatment and going to the counseling center there. So it's nice to meet Bill virtually here. But Melissa Callahan, our Director of Nursing, is really spot on with all of our latest trends and data. And I would love to have a chance to get back to you with her information. Right. Yeah, so that would be a follow-up for me that I don't have that information with me, but I would love to share that because we are seeing that on the inpatient when people do come in and get screened and how we're handling that. I would love to have Melissa either join in next time or I'll get updates from her to share with you.
Great, and feel free if you have an update, if you put that in an email and send that to STAR, we can send it out to the group so that they know what your experience is like where you're at.
Great, I'll ask Melissa for that. I'll see her next week, but I'll ask her for that even before to share.
Wonderful, thank you. All right, that's hepatitis C. We're not really talking about any of the details of treatment because that's not what we're doing here. Any other thoughts before we move on to the mental health co-occurring disorders?
Abby, I just have one question for you. As patients
Sure.
are presenting for medication-assisted therapy, are you taking into, is that, to what degree is whether or not they have hepatitis C or not taken into account by you in terms of decisions on medication-assisted therapy, if at all?
It turns out that the buprenorphine is actually quite safe, and we shouldn't be considering liver disease as a barrier to care for buprenorphine. There was a lot of information out there circulating about Vivitrol and whether you can use that for people who have advanced liver disease. We use some sort of guidelines about if their liver enzymes are 5 times normal that we might want to use caution. But more and more as the evidence is coming out, it seems like the pre-real world studies that showed some concern about liver disease may have been sort of overstated, and that even Vivitrol is probably safe in advanced liver disease. So, so we are still in a position of having shared decision-making with our patients about what they feel is the best solution for them. And liver disease doesn't really get in the way. Certainly a diagnosis of hepatitis C without severe liver damage should never get in the way of using medication-assisted treatment. It's probably one of the things that will help people get to their hepatitis C treatment, adhere to that treatment, and stop transmission. Thanks for that question. A little soapboxy on that. Yeah, okay. All right, this is also a whirlwind tour through some of the mental health or psychiatric considerations along with substance use disorder. I had the pleasure of hearing Brent Hager, who developed this, give the talk, and it was just, it's so nice and clear to give you a framework for sort of thinking through some of the psychiatric issues for MAT and prescribing. And I think the takeaway, just to spoil it right from the start, Bill, this is related to the hepatitis C. None of these are a contraindication for using MAT. And probably they help. So if we look at, we know that for our patients who are coming to us with opiate use disorder and looking for medication-assisted treatment, that the likelihood that they have co-occurring psychiatric disorders is enormous. Oftentimes we're worried about, you know, is this a chicken or an egg? Did it come first? Is it the psychiatric disorder that put someone at higher risk for substance use disorder, or is the substance use disorder driving the psychiatric symptoms that they're having? And the answer is probably yes. So this slide shows what's the prevalence of the psychiatric disorders in general populations versus people with opiate use disorders. And you can see that for the folks in blue is the general population, the orange bars are the people with opiate use disorders, and they are very much more likely to have severe mental health issues, major depression, personality disorders, and PTSD being really high, but all of them more than double the rates for the general population. And when we go the other way around and look at the lifetime prevalence of substance use disorders in general population, this says versus OUD, but what they really mean versus people with psychiatric conditions, that you can look at the lot more alcohol use, cannabis use disorders, which do exist. We need to be talking about that still, while there's a lot of a move toward legalization and medical use of marijuana, and so on. So both directions. And this slide mostly just puts that into a list with numbers, but look at this pre-existing psychiatric disorders, the general anxiety disorder, 11 times risk, bipolar disorder, 10 times risk of developing opioid dependence. So for a lot of our young people who may have underdiagnosed or undertreated psychiatric disorders and may look towards some illicit substances to treat themselves, they're at really high risk of developing a substance use disorder that may last with them for a prolonged period of time. So it's important for us to be able to recognize both. For those of us who are then seeing people who are coming to us with their opiate use disorders, the question really is, can your patient tell you which one came first? Did they have some symptoms of depression or anxiety or other things before they started using drugs, or did the symptoms come on mainly while they were using drugs and go away when they're not using them, or did they start after using drugs but they continue even when they stop? So this runs through those questions. Are they only happening when they're using substances? Then probably it's as a result of those substances themselves, so the opioid-dependent mood disorders and so on. Did the psychiatric symptoms present before the substance use disorder or during extended periods of sobriety? Then likely we're talking about a co-occurring psychiatric disorder. Or were those symptoms present before and during? Then you may have a little bit of both. Sounds obvious, but it isn't always, right? So just trying to think about temporally, how do these conditions present? Our treatment goals when we're talking about co-occurring psychiatric disorders, our treatment goals are to try in the acute phase to get some response, and we consider a good response more than 50% reduction in symptoms, and hopefully to get them even into remission where they have little to no symptoms. And then our continuation and maintenance phases are about staying in a durable remission. And we use this kind of language so that particularly in primary care or in some of our other settings where the counselors are in contact with people, but the psychiatrist is a little harder to get to, that if we're not getting a great response, that person needs some attention so that we can enhance their treatment. So let's look at depression. There hasn't been a lot of studies on that provide us with any empirical support for antidepressant use with buprenorphine, but it does look like buprenorphine itself can help treat depression even without an opiate use disorder. And for those who do have symptoms of depression or a diagnosis of depression, that's actually a pretty good prognostic indicator for buprenorphine, that they're probably going to do pretty well with the MAT. They do actually somewhat better than people without that. So probably that means that it's addressing two disorders at the same time, that it's giving them some benefit for the depression and treating their cravings and their withdrawal symptoms for the opiate use disorder. There is more evidence out there as far as methadone, but it's mixed evidence. So you look, when you see that at the top of the slide, there are some positive randomized controlled trials. In the doctor world, we love our randomized controlled trials that show that for people treated, people on methadone, there's some positive response for imipramine and doxepin, but there are also negative randomized controlled trials for imipramine and doxepin, and many of the other drugs that we commonly use. So we don't really have great data that says this is the best drug to use. The takeaway there is that we don't have great guidance to show us exactly what to do, but there are some pretty well-established practices that we should be using methadone for people who come with co-occurring depression. We should be using buprenorphine for people who are coming with depression and opioid use disorder. And naltrexone, there was some concern that because that's blocking your immune receptors for opioids, and those are part of what help us feel good, that naltrexone might worsen depressive symptoms. It doesn't appear that it does. It was a great question. I was like, I wonder if that would be a problem. But apparently it's not, and we don't really understand why not. So recommendations, someone's coming to our office new for their MAT, and they score a 16 on the PHQ-9, and when we dig a little deeper, it looks like they do have a major depressive disorder diagnosis or an opiate-related mood disorder. We can't really tell. The recommendation is first stabilize them with their MAT for about 6 weeks and see what happens. For many people, it's an opiate-related mood disorder. It's going to get better. For some people on the buprenorphine, it may be a little bit treated and it's enough. So as long as they're not in crisis, different situation if they're in crisis, they may have some remission just with the medication-assisted treatment. On the other hand, if they continue to have symptoms, then we're going to treat them. Most of what this slide is talking about is using evidence-based approaches for treating the depression, following with the PHQ-9 so that we know whether we're getting a partial response or a good response or whether we've gotten to remission, and using a team and step-based care for that. We love our team. When we look at what are some of the treatments for major depression, that psychotherapy and medication can both be effective, and they're more effective together, and the more severe the symptoms are, the more effective each separately and the combination can be for treatment. So we in general recommend that people should be in therapy plus medication if they're able to tolerate that. And if we were going to do a sequence, and these sequences, I just love these slides for these sequences. Start with psychotherapy. Next up is your SSRI, that's the fluoxetine, Prozac, and all of its friendly cousins. If not that, move to your SNRI, those are the effectors and the Cymbaltas. If not that, move to your bupropion or Wellbutrin. If not that, Remeron. If not that, a tricyclic, and it kind of goes on. ECT is in here. I'm not, this is not a primary care treatment. We probably are not going to get past the tricyclics. They are offering use caution with the MAO inhibitors, as we always do. There's a high risk if they're on medication-assisted treatment for a serotonin syndrome. So my line is after the TCAs, and probably before that, I'm looking for some support from a psychiatrist to help us refine our treatment plan. But this is our stepwise treatment plan. Anxiety disorders. We already mentioned that anxiety disorders are really common and that anxiety disorders may be an antecedent for many, many of our patients. We'll see similar patterns here that panic disorders are common. Again, psychotherapy and medication can be helpful. Start with psychotherapy, then your SSRI, those letters, SSRI, then the SNRI, and then imipramine, which is kind of interesting. But for those of us who are prescribing, it's nice to see that the patterns are similar. So we will continue down on there that the social phobia is similar. The incidence is really high. We hear a lot of people talking about social phobias. I think that comes hand in hand with the stigma of the substance use disorders. But interesting to hear people's stories also of having social phobia well before they ever started using drugs, and that they were using these to try and connect and feel normal. We need to treat that. Start with psychotherapy. Move to your SSRI. If not that, then the SNRI. And those of you who aren't prescribing will see these patterns. And it's great to know and ask questions of, have we tried these things, right? The general anxiety disorder is really common. The pattern in general is going to be similar to what we have seen for the other anxiety disorders. That we're going to start with the therapy. We add in here the hydroxyzine, fancy Benadryl. That's been very helpful for a lot of our patients at any point in their treatment, that it can help take the edge off of some anxiety, and sometimes will also help them have the presence to then try some of the breathing exercises or some of the other coping strategies that they're learning about in their therapy. Here we have it turned around a little bit, go to the SNRI and then the SSRI, but one or the other of those is going to be important for treating their anxiety symptoms over time. What really is difficult for people is that it takes a long time for them to work, and they'll feel the side effects before they feel the benefit. But with the right kind of counseling and support and a little bit of hydroxyzine, that they can sometimes get to where they need to be. We're seeing a lot more people using gabapentin or pregabalin for the anxiety disorders. They can be really helpful. And then buspirone is sort of a last resort here in this particular list. You see that benzos are not on there for long-term treatment, and that we're trying to avoid benzodiazepines in general for people with opiate use disorders and for people who are on medication-assisted treatment. Lots to talk about benzodiazepines and the high risk of mortality with the withdrawal. But also we see a 2 times increase in all-cause mortality for people who are using benzos that are on medication-assisted treatment. It increases the risk of overdose by promoting some of the respiratory depression. In our early days, we were using this almost as an exclusion criteria. So here's one bill. That if people were on benzos, when we were first getting started, and the wisdom at that time was people shouldn't be on MAT and benzos because it's just too dangerous. Over the last couple of years, I think the general understanding has evolved a little bit that the risk is certainly much, much higher, but that asking people to make a choice probably doesn't make a lot of sense, and that we can manage these together for people who are not showing us a benzodiazepine use disorder. So if they're able to control their use and use as prescribed, that we shouldn't use that as an exclusion criteria for medication-assisted treatment. But we do want to be having a collaborative relationship with whoever it is that's prescribing the benzos, and hopefully work on getting them on a treatment sequence that shows better results for long-term use. The Lyrica or pregabalin is also risky, so we need to be careful about those also. PTSD, lots of psychotherapies, including our favorite down at the end here, the SS is seeking safety. These are different kinds of treatments that we can use, the cognitive behavioral therapy, prolonged exposure, EMDR. Hopefully lots of your programs out there are using some of these counseling techniques. And then as far as medication, the prazosin is one of our interesting ones that shows up here for PTSD that isn't on the other lists, that can help with the hyperarousal and with nightmares. Insomnia is a whole nother ball of wax, and then we'll be done. One of the things that I think, most people in our medical systems are looking for a pill to fix their insomnia. And with opiate use disorders and people who are on medication-assisted treatment, one of the things we often overlook is sleep apnea. So if people are having trouble sleeping, we need to be asking questions and screening for sleep apnea. Then we need to counsel people quite a bit on how to use that CPAP machine, because people tend to hate it. But we aren't going to be successful in treating their insomnia if they have sleep apnea by using pills. In fact, we'll probably make their sleep apnea worse if it's central sleep apnea, and that's dangerous for people. So our insomnia treatment is first check out their sleep disordered breathing and treat that. Psychotherapy, the cognitive behavioral therapy for insomnia. There are actually quite a few phone apps out there now that are pretty helpful for that. Sleep hygiene, which is sort of stimulus control, and relaxation treatments. I'd be curious to hear what your favorites are for insomnia. We hear a lot about people suffering from their insomnia. The general sequence, start with psychotherapy. Doxepin, probably the best for people who are on MAT. Then moving on to the Ramelteon and then Trazodone. We see a lot of people on Trazodone. It doesn't seem to be as effective as some of these others. And then melatonin. Avoid disease. So our Zolpidem, these have a 1.6 times risk of overdose death.
So melatonin is last option because it's
Not very effective.
right. Okay,
Yeah.
that's what I was like, least effective.
So,
'Cause
yeah, so
usually
it's,
that's where you
I mean,
start.
one of the things we like about the melatonin is that it doesn't do a lot of harm, but it also probably doesn't help all that much. All right, so our summary is that there are a lot of co-occurring disorders and that there's a reciprocal relationship between these disorders and the substance use disorders. Don't have a lot of literature. Our first line is to stabilize the opiate use disorder with the medication and with good treatment, and then make sure that they have access to psychotherapy, and look at our treatment progression for medication, and use some way of measuring how your treatment response is when you start medications. Avoid the Lyrica and the Z drugs and benzos if you can, but don't use these as exclusion criteria necessarily from medication-assisted treatment, because the benefits of the medication probably, for many patients, outweigh the risk, but they need a good, solid risk assessment. Questions about that? Or some responses? There are also 3 pages of references that will be posted on the website. So if you want to look deeper at some of the sources for that, those will be available to you on the website within the next week or so. Any thoughts on the presence of co-occurring disorders, or things that you've seen, or partnerships that you yearn for?
We have people who joined us. We have a Donna. I don't know Donna who.
Great. Okay, so let's.
And Carrie.
Great. Okay, so thank you, newcomers, for joining us. We'd love to hear a little bit about you. Carrie, can you unmute yourself and introduce yourself? Or perhaps Star can unmute you and.
She's with Rosemary.
Oh, yeah?
Yeah, she's one of the CHW.
Yeah. And also having the same audio issues? Okay.
The chat, she did say she was a rural CHW though.
Oh, great. Carrie, welcome to the ECHO. Donna, can you introduce yourself?
Donna?
We'd love to hear who you are. I don't know. Carrie, we hear a little shuffling.
Yes, I actually figured out how to how to call in. I can't call in through my computer. Apparently, I don't have a microphone on my computer, but I was able to call in by phone. So I am here now. Hello, everyone.
Hi.
Hello.
Hi. Welcome. Still hoping for Donna. And Donna, if you can hear us, feel free to jump in at any time, but also if you want to send a chat if you're having trouble being heard, we'd love to hear from you that way too. So we're going to move on to a case presentation. And as usual, if anybody, when we're done with this case, if anybody's got another case they want to just throw in as an impromptu, we love that. So. Oh, Donna just sort of made herself a little bit available. And again, why is it doing that?
Try display settings. Do you have that? See how it's up there? How it says display settings above the presentation? I wonder how to get up there. You're getting closer. It's fine, that bar.
New.
Let me try.
Anyway, all yours.
Okay. So this case was referred to us by one of our providers, Dr. Tim Daly. And I think it's an appropriate case, especially for this presentation today, because it's going to tie in a little bit about mental health and how we can better support patients with co-occurring disorders. So get started. So we have a 43-year-old Hispanic male. We want some help with non-medication treatment. He's not aware of the presentation, and he did not help develop the question. So for strengths for him, he consistently shows up to his visits, so he's serious about treatment, and he's really motivated to stop using and to get more control over his mental health and of his opioid use disorder and polysubstance use, as you'll later see in the case. So for the question that we have for him, and kind of we generalized it for other patients as well as other individuals, is for patients with schizophrenia or other co-occurring disorders and polysubstance use who do not want services from like an ICM or those outside services. What other type of treatment supports can we offer them? And how can we help them get more engaged with those services? So for this individual, he presented to NHCLV for treatment in October of 2018, originally wanting Vivitrol, but he was having difficulty detoxing for those 7 to 10 days. He was a transfer from Step by Step. I'll be referring to it as SS. If you read that on one of the slides, that's what that is, Step by Step. Due to attendance inconsistency. He was going for 5 years for medication assisted treatment. That's what I saw in the paperwork and also what the patient stated. So he was going there for MAT and for mental health. He is supported by his girlfriend, who he lives with. It's a safe and drug-free environment. She comes to appointments with him, to some of them, and he does speak about her very frequently and how he really wants to kind of make her happy, make her proud, and but he's also struggling with severe mental health instability, which makes it difficult for him to maintain sobriety. He kind of goes back and forth between using and not using, and usually it's around the same time where he's having a little bit more trouble with his mental health. Right now, he's currently receiving Sublocade. He just had his first dose recently. He's due for the next one, and he actually just stated that he has been doing really well on it, and he wants to continue it. It's the most stable that he's ever felt so far, so hopefully that continues. And then he has an active diagnosis and a viral load for hepatitis C treatment. He's never been treated before, but it's something that we're working on with specialists, so that's being taken care of. For housing, he rents an apartment with his girlfriend. Education, he attended school until the 8th grade. Don't believe he got a GED or anything like that. He has no legal involvement. He doesn't speak of any incarcerations. He has never been incarcerated. He hasn't had any issues with the law. And for ACEs, so he does state that his father abused alcohol and cocaine, but there was no physical violence in the home. It was a lot of just trying to deal with the family dynamic and support his father at the same time while he was struggling with abuse for alcohol. And then for employment, he is on mental health disability, so he receives Social Security. For substance use disorder, we have heroin and cocaine. His first date of use was 15. So when we think about it as like the what came first, as we were talking about before, for him, he does state that he did have some anxiety prior to starting his use at 15, but he just thought of, now when he looks back on it, he's not sure if it was just anxiety that he got because of his father using alcohol and kind of the kind of effects that it left on his family, or if it really was like a generalized anxiety disorder, but he wasn't receiving treatment or anything like that. So he first started using heroin and cocaine at 15, and his last date of use was in April. But again, he goes back and forth. He did achieve some sobriety for some time, and he relapsed. He achieved sobriety, and then he relapsed again. It all depends on how his mental health is doing. So it's really affecting him. He doesn't have any overdose history. And then for labs, the urine drug screen confirmation, so a consistent pattern of heroin, cocaine use, that intermittent use. Right now, it's in the time where he's using more consistently, but hopefully with Sublocade that will change. For comorbidities, for medical and behavioral health comorbidities, we have hepatitis C, type 2 diabetes, opioid use disorder, low back pain, elevated transaminase level, schizophrenia, major depression. And then for medications, we have Celexa, Seroquel, metformin, and Sublocade that he's getting monthly. He just started some treatment, I'll talk about just on the next slide, but he did start some treatment at Omni for mental health. So we'll see if any of the medications like Celexa or Seroquel change in the near future. For past behavioral health treatment, community support, he did have an inpatient stay at St. Luke's in 2014. He states that it wasn't due to any like suicide or homicidal ideation. He just really needed some help with mental health at the time, so he got some help step by step in getting into an inpatient stay at St. Luke's. Again, step by step for MAT, medications as treatment, which was in the form of buprenorphine and mental health from 2013 to 2018, and then he received mental health services at NHCLV in 2018 for a very short amount of time, and then because we were helping him with therapy and bridging some of his psychiatric medications, and he is now enrolled with Omni, where he currently receives medication management. One of the things that Dr. Daly wanted me to put out there was several months from October when he started to about just maybe 1 or 2 months ago, where he was stating that he was receiving mental health services. Even though he left step by step, he was receiving it somewhere else, he stated, but he was just waiting on seeing a psychiatrist. So he was able to see the therapist, but he was just waiting for an appointment. So we were bridging his antipsychotics in the meantime, but then after several months, it became apparent that he really wasn't seeing a psychiatrist or a therapist. So that was something that was news for us, and then our care managers really tried to help him find services that he can get to due to any transportation or issues or anything like that to get mental health treatment. And now he's at Omni, so that's good. There you go. What motivates him to change? So his girlfriend is very supportive of his sobriety, and this motivates him. He vocalizes he's tired of using and he wants to be able to just function daily without using. And that along goes with the mental health. He wants to it's like how we spoke about in other cases, he wants that normal feeling. And then he's also concerned about his physical health and the impact or repercussions that continued polysubstance use will have on his overall well-being. He says, I'm in my 40s, I'm only getting older, I need to start taking care of myself, and if I keep using heroin, cocaine, and I don't get some control over my mental health, this is only going to get worse. So he really wants to stop this before it gets worse. So he does have that insight. I definitely think that's a strength for him as well. He does state it. He's able to vocalize that. So proposed diagnosis, same thing as before, that we had the hepatitis C, diabetes, OUD, some low back pain, chronic pain, schizophrenia, major depression, and then identified goals and treatment goals. So we started him on Sublocade in April, and he's very happy with the decrease in cravings and withdrawal. For him, he was just used to those symptoms. He was starting to just realize or just accept that maybe that's just part of my life now. So, but he's very happy that Sublocade has been able to kind of change his view on that. So he wants to stay on it. So that's good. Another goal we have is encouraging him to continue mental health treatment in Omni because it's something that works for him. And he himself says that he does better when he has consistent engagement with mental health services, so he wants to keep that up. the Mavorite, which is the antiviral for the hepatitis C, one of the medications that we discussed prior, has been approved by his insurance. So right now, we just are working with, right now, I believe he has like some fines that he has to pay from things from the past. And so they're waiting for that to be worked out before they start him on any treatment, because they're afraid that if for any reason he does become incarcerated, then he won't be able to continue treatment. So we don't want to start something that won't be continued. So they're working on that right now. And then, but the plan is that he will be starting it. So to me, that means that he's most likely not going to be incarcerated. So, but so we're going to encourage him to keep up with his treatment, regular dosing, and continue to see the specialist as needed. Here's summarization.
Okay, let's give it a try. So we've got a 43-year-old man who has some diagnosis of severe mental illness, schizophrenia, and with that anxiety disorder or major depression, who has been struggling with polysubstance abuse, mainly heroin and cocaine, since the age of 15, who has some intermittent periods of remission, but then relapse when his mental health is more poorly controlled, and has been experiencing some difficulty maintaining mental health care. Who has recently started on Sublocade, which has improved his opiate use disorder, but is still having some difficulty really engaging in his whole package mental health care. So the question being, how do we support him? The MAT seems to be in a good pattern, but less so with the treatment for his mental health.
Think that works?
Okay. So for our team out there, we start with clarifying questions. What are things that you want to know more about this patient? So what are some questions you have about this guy? And we'll start with you guys out in Zoom land. What questions do you want to know more about?
Hi, this is Carrie. I have a question. Is it possible that he could get his MAT and his mental health treatment in the same location?
Not where he's at currently. So where he is placed right now for mental health, they won't be able to give him that MAT as well. When he was at Step by Step, that was something that was being done for him, but due to the attendance issue, he was discharged from there.
So other dual programs locally that might be able to give him both buprenorphine and psychiatric care would be Pyramid, right? And NET. Those are the other two that have dual diagnosis programs.
That doesn't do
it? No.
Is he English speaking?
No, that was one of the other
I didn't
things.
think so.
We're trying to find some
Yeah.
And that does end up being a big barrier for the dual programs in general.
Yeah.
Is the language barrier. So he's Spanish speaking only. All right, other questions out there? And we invite questions from everybody. So Amy, if you've got some burning curiosity, we'd love to hear it. Anybody else? What do you want to know about this guy?
Excuse me, on the mental health side, has he been involved in like a partial hospitalization program of any type?
No, he is not.
So it sounds like he had inpatient stay not too long ago.
5 years ago, 4 or 5 years ago.
But it looks like from inpatient, the step down was back to step by step, where he was getting a dual program there where he's getting the MAT. And then I guess, I mean, it's interesting to me that the tricky part there is that it sounds like Step by Step was a good environment for him because it offered lots of support, but he got discharged for lack of attendance. And that's
There was also,
after 5 years. Which
yeah, I think, and when I look back on our notes and my discussions with him when he first started treatment with us, it sounds like it was one of those times where he was really struggling with his mental health, possibly while he was using. And it was just a very, very tough time for him. So I'm really surprised about the attendance issue.
Has he ever had an acting?
It was offered to him, something like an ICM and like a team like that was offered to him. But then because of his like mental health, one of the biggest things that he just didn't want people coming into his home or like going out in the community. That paranoia type of aspect.
He could come to his MAT provider.
So we're still on clarifying questions before we get to suggestions. Here? Sure, in here.
Do we know some of the things that like he enjoys or hobbies that he uses? Maybe coping skills when he's struggling with the mental health.
He doesn't have many activities. He likes to spend time with his girlfriend. But other than that, he's never specified any specific activities that he likes to do.
But like even what they do together, like do they take a walk? Do they watch movies? Like
yeah, from my understanding, they pretty much just stay home. And I believe she works too, so he spends a good amount of the day by himself unless he has appointments to do.
Okay. Maybe just asking those questions will help answer the main question, how to get him engaged. First finding out like what things he enjoys. So has a CRS been suggested? I know you said ACT or ICM. There may be a Spanish-speaking CRS that can see him out in the community as opposed to in his home. Has that been suggested?
I believe our care management has offered those things to him, and then he doesn't engage with them.
Neither. Okay.
And then it just becomes like, oh, I have you guys, I need that.
So I'll put on my doctor hat. Do you know what his dose of Seroquel is? I think one of the things that we were talking about in the didactic piece is that oftentimes people are on a medication for something, but if we're not assessing what the effect is, they might not be on an adequate dose, or they might need to get that changed. And it sounds like we've been refilling a medication, but I don't know whether it's at an adequate dose for him. So that's kind of an interesting thing about just what's the dose. And do you know if he's been assessed for PTSD?
No, he has not. We haven't been able to get a psychiatrist to do an assessment for him. We have like the records from like that stuff. It's not on there. Something that we thought of though. I remember I had spoken to Dr. Daly about something coming back for head, but we wanted him to get into psych, and we finally got him to comedy. So we're hoping to get some information from that.
Yeah, that's great. Christina, got any more questions? I guess I do have one more question. If he's worried about fines and potential incarceration, it sounds like he does have a legal history, not a no legal history. So I'm curious about do we know what that is?
I'm not sure exactly what it is. From what I understand from what he states, it's just things that happened in the past that he just never dealt with. But it's nothing like, he states it's nothing like a felony or anything like that.
Like a retail theft probably or something.
Yeah, maybe.
But we don't know. So that's
usually people don't worry too much. I mean, they can go to jail for parking tickets, but they just kind of be like, just go and put $50. You know what I mean? Like they don't worry about it. I think it's probably more a misdemeanor charge of some sort that maybe there was a bench warrant.
Okay, so we have a dilemma still, that we have a guy who has recently gotten better treatment for his MAT, has recently gotten to Omni where he will sometime soon see a psychiatrist possibly and get a new psych eval that will update things, but has been a little slippery in terms of other supports, or it feels that way to the team. Some good questions coming out, particularly about, what are some of the things that that he might like to do? Like,
I do have another question.
Yeah.
Sorry. Any physical limitations?
No, he's able to ambulate. He does have like that lower back pain that sometimes gets in the way. So anything that's like very repetitive, it might.
There's like obesity related or not either? It's just lower back pain. Okay.
all right, so now let's put our collective brain together and think about what kind of suggestions do we have that might be helpful for this guy. We've offered some things. They haven't landed. What's the next step? What do you think? So we'll start with you guys out in Zoom. That's Laura, Carrie, Donna, Amy, Bill. What might you do with this guy if you were seeing him next?
So
Whoops, I think you re-hit the mute button. Unmute yourself again.
okay.
There you go.
I would, and I had written down in my notes right before Lisa spoke, and I totally agree with her. Hobbies, passions, whether art or music, like Recovery Partnership in Bethlehem, for an example, with the Artists in Recovery programs, anything at all that could foster something for his future, like one little gleam of hope that this is something I might want to work on in the future. I would invite him to Rally in the Valley. I'm one of the coordinators for that coming up on Sunday, but I wouldn't want to overwhelm him. It's going to be huge at Steel Stacks, but I would just kind of invite him into the community to try out at his own pace or his own liking smaller events, or if he might possibly be open to attending. He will see so many people in recovery. There's going to be an artist portion, making a quilt, a community mural, and see what sparks. Is it music? Is it art? Adventure recovery will be there, hiking. Is there something in nature that would, meditation, yoga, anything like that that might spark something that he never thought about? So that would be right on target with what Yamalisa said.
And the salsa band, since he's Spanish speaking only.
Exactly. Woo! Yep. Hector Rosado.
Yes.
The Latin jazz experience with Hector Rosado will be outside, so he's more than welcome to come. And I personally would love to say hello to him. I will not mention the ECHO project, of course, but welcome him as one of the coordinators and take him around. So if that's something I could do.
It's a beautiful suggestion. Thank you. And I think that's all about the power of community, right? And
Yes.
how to connect. Thank you.
Is there a reason the MAT provider won't prescribe, or has anyone spoken about antipsychotic injectable, just to get him a better baseline, and then maybe he can take advantage of some of these things going on?
I think what we were doing was because he was stating that he was getting some type of mental health treatment. He was just waiting for a visit with the psychiatrist, and we didn't want to add anything if he was just going to see them. But then after a month or two of seeing them, he still wasn't seeing the psychiatrist. Then we realized he really wasn't seeing therapy. And now that he's at Omni, we just didn't want to start something that would possibly be changed or decided against for any reason.
I think that brings up a really interesting point, and I'll, you know, anybody that wants to give some input on this one too, but I think it's interesting when we're collaborating across organizations to know when to move forward more and when to sort of stay back and wait. And I think particularly, I know for, you know, our organization, we're a federally qualified health center. We have primary care clinicians who have a pretty broad scope and integrated behavioral health team. But currently we don't have a psychiatrist who is available to us. So one of our dilemmas is, how do we get input from psychiatry? But if this guy is going to Omni and maybe doesn't have that psychiatry appointment yet, if we have a consent, what's preventing a doctor-to-doctor conversation to see if we could get started someplace? Maybe that's something to really consider too. Like, there are times when that real-time conversation, there's nothing to replace it.
Absolutely.
So there's a suggestion that we can think about. So I think it sounds like he does really well with an injectable for the buprenorphine.
It took a while to get him to agree to Sublocade. There was a lot of like missed appointments, I can't make it, things like that. And then we finally, and so far I've seen that as a pattern for a lot of our patients. Like, just getting there, it takes a while.
There's a scare factor, I
yeah.
think. It's a needle, which might sound funny because people will automatically say, oh, they use heroin, they inject, but it's not different. You don't have control. You're not holding it.
But for the most, I would say it's the vast majority of our patients that once they are on the Sublocade, that it is very helpful. The only situation I can see where it isn't extremely helpful is when they don't have a good hold of their mental health, and that's when Sublocade may not be working as effectively. But so just to me, that's just another reminder that we need to make sure that we are keeping individuals engaged in this when they need to be, in order to be successful in something like Sublocade or MAT just in general. It's a treatment.
Let me go back to the clarifying question. You said his girlfriend, she's rather supportive of his recovery. Okay. Is it possible that we can encourage him to bring her to his appointment?
She comes to some of them.
She comes to some of them?
And I think it's due to, like, probably because of her job, her employment.
Okay. Maybe enlist her as an ally, so to speak, to reinforce some of the things that we're trying to do.
Right, there's good evidence out there that involving families in treatment helps maintain remission, and people do better when, so I think we all have stories of when that hasn't gone well, but overall, you know, finding the support networks and building them up as part of the treatment team can be really helpful.
Yeah, there is a Spanish-speaking NA meeting on Wednesday evenings at 6 at Mars. It's downstairs in the basement, so that's
Wednesdays at
6 p.m. So it's open to the public. And it is Spanish-speaking. It's probably the only one in the area that's right now up and running. I don't know whether a referral to drug and alcohol, but not to see it as treatment, but as support, is because that gives them, when they feel that they're going voluntarily, it allows a lot of the clients to really feel in control. I mean, and he's young. He's 43 years old. Seems to be able to be active and kind of get around places. So just maybe having a set, you know, weekly group that he gets to speak in his language and just relate on a different level with some of the guys. Most of our clients are males, and all are Hispanic because they're all Spanish speaking. So that, and finding out just what does he enjoy. I think that's going to be a really important conversation. Definitely including, you know, his girlfriend's going to be important. But overall, if possible, maybe getting him to the NA meeting, a CRS referral so that he can see it differently and understand that CHWs, their job is not peer recovery, but the CRS is, and just knowing that they're not just going to talk to him about, you know, you need to see a psychiatrist, you need to do this. No, let's go to a meeting together. Let's have coffee. Let's talk. Let's, you know, you're home alone most of the day while your girlfriend's out at work. Let's just hang out for an hour. And that will be more of a friendship. It will feel more natural as opposed to just somebody else that has a job that they get paid to see me for. I think that will help.
Is your CRS from nursing?
Not CRS, CPS.
Oh.
Yeah.
Can that be in Easton too? Sorry, I just never really thought about these questions.
Can what be in
Like
Easton?
in Easton.
Oh, he lives in Easton?
Yeah.
Okay.
Yeah. Acting will go to wherever. Easton has a forensic CPS program. They don't, as far as I know, they don't have Peer Star. They don't have a Spanish-speaking CPS, but you can, or they didn't last year. You can always call. You can always have case management call and see.
Yeah. Being that he's in Easton, maybe he can make it to Bethlehem. And I have written it down, but I thought it was from my own time. At the Bethlehem Recovery Center, there are a lot of different activities, and there are Spanish-speaking individuals there that he can talk to. And Northampton County does have the intake unit that they do have, again, Spanish-speaking services that, you know, he could feel more comfortable with.
Great bunch of suggestions. It sounds like if we were going to sum that up a little bit, that helping get his mental health under control the best we can and collaborating a whole team with his psychiatrist will be helpful at an injectable. He may have some positive experience now with injectable Sublocade, how much that helps. Maybe this would be something he'd be open to that he wasn't before. Assessing for PTSD and making sure that he's getting adequate treatment for that too. And on the social side, tapping into his passions and the things that he loves and introducing him to the community and giving him a wide range of ways to enter there that could make a huge difference when he's feeling when his mental health is on its more stable moments, that's something he could really do. And bringing his family in intentionally as part of that treatment community for him. Those sound like great suggestions.
There's a baseball game coming up June 5th.
That's great.
That they're going, yeah, that the Iron Pigs, that's going to be the second out of 3 games for the season. So they're going to be representing like Hispanic heritage. So there'll be the cookies for the day, and they'll serve like Hispanic food, and the tickets are like $10. So maybe just kind of getting in, and actually a Groupon might even have them cheaper.
Well, that's great.
So getting them out.
Oh, no.
I already got my tickets, so I'll be there. I went to the last one, so I'll be in all of them. But I mean, baseball, food, and music are big things for us, so it might be for him too.
Great suggestion. Any other thoughts out there in Zoom land? You guys are good? Anybody have another case that they want to bring up? Something on your mind? Got any?
Possibly. I'm like trying to think. I do run groups. I don't have it in front of me, but just off the top of my head, we have a Hispanic, fully bilingual male, though, but he is on the Hispanic track with us, and he is coming to Mars through his EAP because of a recent UDS positive for cocaine, and has only been in treatment for about 2 weeks, and basically like pushing to get a letter stating that he's cleared to return to work. So there has been, well, we need to see your progress, basically. But the issue now is that somehow he's back at work already. And our concern is that he's not attending group already. Again, I think this would have been his 3rd week in treatment. So basically attended one group, orientation, well, assessment, 1 group orientation, and 1 individual. And already called yesterday saying that he couldn't be in group today because of his work schedule. Now, it appears that there may still be continued use that he's minimizing to his job. During the assessment, client stated to have just used once in the last 5 years at a party that he was kind of encouraged. There were, girls. And then during the orientation session, opened up and stated that he is married, but wife has, issues with intimacy, so he does have an outside relationship, but it's with a younger girl, and she uses cocaine pretty often. So now it's, again, this is a professional male that holds a position coming through EAP and needs treatment to be able to keep his job. How do we help him see the value in, 1, stopping his use and being honest with it, and 2, referrals that could potentially be available to him to keep him in treatment. You're welcome.
Okay, so we have a young professional who's got an employee assistance program, mandated participation, and is not, from the point of view of the treatment program, has not actually engaged in care, but is already back at work and using that, saying that his schedule is interfering with his ability to participate. So it sounds like there are sort of 2 pieces of question. 1, how do we encourage him to engage so that he can get the benefit of the treatment? But 2, what's the ethical responsibility for someone who's in an employee assistance program who has not really fully engaged in care? That's a great question. Do you guys have clarifying questions out there about this person?
Have you been able to talk to the EAP program about how he got back to work?
We just got this information this morning, so it's, it just came in an email. He didn't call me to cancel group directly. He called the reception and just like, hey, let her know I can't make it because of my work schedule. So that can definitely be our next step, just reaching out to the EAP at his job, like, hey, how did this happen? So we can definitely do that next. Yes.
More clarifying questions?
Does his wife know he comes to Mars?
I don't know whether the wife knows. He didn't even list her as emergency contact. So.
Yeah, that's something, and then probably a negative.
Yeah.
Any other questions out there? Gina, what are your case management questions?
Well, for this, I don't know. I mean, case management is all about lacking resource and giving them, and it seems like he has a great resource, which is EAP, that can sort of point him to other resources like Mars. I don't, does he have a mental health diagnosis? No. Okay. And he seems to have stable housing with his wife. It's just maybe not truthful stable housing.
Right. I mean, he says that it is an open relationship. She's fully aware that that he has this outside relationship. I just think the big issue is the being honest with his dependence on this substance. He completely minimizes it to everyone.
Where does he work? What does he do?
Yeah.
He works in social services, not with substance use, but more with immigration and children.
Other nursing questions? Nurses? What do you want to know about this guy?
the main issue is that we need to get him to come to the group session, correct? But he needs to go to the sessions in order to keep his employment, correct?
Yeah, it is. But just in speaking with him, he'll be able to manipulate it in a way that they'll just ride along with minimal participation. There's a lot of spinning that he's able to do.
How long has he worked at this particular job?
About 11 months now at this job.
But it's fairly not like a veteran.
Right, no, I mean, and they're giving him the opportunity to seek treatment because they don't want to lose him. He's a very valuable part of their team. And, you know, they want to make sure that, you know, he gets the help that he needs and be able to remain at work.
So my question, and this is out of really not knowing too much about what is the relationship between the treatment program and the EAP program? How does that work? I don't know if Bill, if you know more about this, or Laura too, but when he's referred to you for services, are you given sort of their treatment plan? Do you know what the stipulations are and what the consequences are, or do you not know that and you're just told to offer him your usual treatment?
So he came a step ahead of the referral. So he's technically a self-referral, but doing it because he knows that they're going to require it anyway. He hasn't even fully gone through the process, which is the question as to how did he make it back to work already when they were going to refer him to treatment anyway. So we didn't receive an actual referral with any information. It was just like, I know I need to do this. I've been out of work for a week and I need to get back. So how do I start? Where do I go? Tell me everything. And again, he came into basically 3 sessions and then has missed the last 2, pretty much.
That's smart.
So again, is that been a benefit?
Do any of you guys out there work with EAP programs? I'm trying to figure out which way to go to be there.
Yeah, we work with a lot of EAP programs, and her situation is interesting, how he's trying to beat the referral in. You know, certain EAPs, like the EAP obviously acts as the broker between the employer and, you know, the identification of the individual, the employee, and the treatment program. And what I was trying to do is, like, what are your expectations? First of all, is he off work until he is assessed and involved in a treatment program? And if so, you know, are the expectations that he complete the treatment program before he goes back to work? Or, you know, and usually the EAP is looking for a recommendation as to, like, what level of care you're recommending for the person. And they can kind of act as the conduit to go back to the employer with that information. What's really interesting here is you didn't even have the opportunity to inform anybody that he was involved, that he was there for X number of sessions, and he's back to work. So I'm kind of confused and maybe concerned of what he's reporting to the employer as opposed to it going through the EAP program, because we're really limited in substance abuse treatment as to what we can tell an employer. So usually the avenue for that to happen with greater latitude is through the employee assistance program. But it's obvious here he's trying to manipulate some things in his favor, and you may need to wait for that official referral to come through.
Yeah, so I think, you know, like I said, like he kind of took a step ahead of the EAP, and possibly the referral may not have even truly made it from the boss to the EAP, because he right away, like first session, like, you know, do I get something stating that I was here? It's like, yes, you do receive an admission letter, and the admission letter does state what level of care is recommended, what your group schedule is. And then the next day he was there again, like, okay, so do I have a letter stating that I'm in treatment? He's like, you haven't come to anything yet. That was just your assessment, and you got that. So it seems as though it was, okay, that admission letter got him basically a direct line avoiding EAP to the boss, just saying, see, I went, I did it, I'm doing it. The other part is I believe that he needed to provide a clean UDS, you know, like just with, you know, no substances. We did 2 or 3 First one was still positive, which is why the admission of, okay, I kind of use a little bit more because my girlfriend uses. And then the next one was basically a cold cup of water. And then the next one was a warmer cup of water. So there have been 2 clean UDS screens that weren't probably urine, at all.
Do you guys tell him, like, hey, this is obviously it's water? What did he say? I'm curious. Like, did he admit it?
What are you talking about? What do you mean? Because we can't test. It's not, it's water or urine. It's just literally a cup. Like we don't have any. We don't send them out.
It doesn't
either.
have little biometric things on it that say anything about.
They're like urea. Like no. It's just temperature. So they're not reliable. They're not like medical grade. They're not. It's just for our record.
Information is it.
Right. So he probably provided the same urine to.
So the only real supportive environment you probably have is work. Because at home like that, that's his girlfriend, right? Or is it?
They've been together for many, many years, so he probably considers her his wife. Yeah.
She's using.
No, not the wife. The wife is nice. It's the girlfriend, the young girlfriend.
Oh, okay.
But the home is still probably not supportive because there's obviously, she has an intimacy issue, he has another girlfriend, like.
Right, yeah, home is probably
little...
just home, wife probably, he just does whatever he needs to. The machista, Hispanic household, like, he's the boss, probably, so.
Okay.
Used to getting his wife.
Do we know anything about his ACEs or trauma history?
So, yes, from the assessment, father was not involved. I don't remember whether passed or just left when he was around age 2. He was the youngest of a lot. It was like 7 or 8 children. And his mother became very ill, so he dropped out of school and helped in the home. So he was basically like the caretaker for her until she passed when he was 15. And then at age 15, he was already taking care of the home. So he, kept an apartment, like he had a job, he did everything for himself. There's a lot of anxiety that presents and OCD as far as, so, it's not diagnosed, so it's not actual diagnosis or treatment that he's receiving, but he's very particular on things that he does, even the way that he speaks. So that's definitely prevalent in him and his behavior.
Suggestions out there? Further ones? We've talked a little bit already about the value of being able to talk to the EAP provider themselves, but that hasn't been available yet because you don't even have a referral, and may not happen.
May not if the boss, if he bypassed it through the boss. We don't know. That's the thing. Now he did attend one individual session. Seemed that went really well. But again, it's one of those that it's a lot easier to manipulate one person than it is to manipulate a group of peers, which is the issue. Like we need to get them in group because there's a lot of things that you can spin in a one-on-one session or with your boss that likes you a lot. And then,
and needs you.
And needs you. As
needs you energetic.
A group of your peers that can see right through the BS.
Yeah.
So, yeah. To them, it's basically like, oh, you're not as productive.
You're a better person.
Yeah. Well, this comes up a lot, right? When there are people that are in the support network that get a lot of secondary gain from ongoing use or ongoing substance use disorder, one or the other, because the system sort of depends on that piece of dysfunction there, one way or the other. That's a really difficult one, particularly with the ethics of this is someone who's in a professional role.
Yeah.
Can I ask one more question? Does he have children?
Not in the home.
No.
No, they're adults.
Maybe that could be a spin if he ever comes back. Like, listen, you want to.
Well, he does have grandchildren that he has a relationship with, but again, none of that is lacking. You know what I mean? Like, he's very much involved. He's active.
So he's functionally using
Absolutely.
cocaine.
Yeah. Yeah.
So other than like going to work, what are like other, have you identified any other motivating factors like in his life? Because I thought about that because you mentioned children. We haven't identified any other motivators.
He wants to get his CDL, which was the reason why they found out, because he needed to complete a physical and provide a urine screen. Because they basically called him, like, hey, within 24 hours, go give this urine. And he gave it, and it was positive, which is how they found out. Because otherwise, I don't even think they test. So he wants a CDL. He wants to move.
So he's looking to leave this job anyway.
He's going to use it with the job.
With the job.
Driving bigger vehicles.
Transporting.
Okay. Because he works with children, yeah.
That's interesting in the sense that maybe he wants to get away from his home as much as possible.
Maybe. He works long hours.
Sounds like this one has to evolve a little. Yeah. You're in that uncomfortable moment of uncertainty, right?
Yeah.
So in a few of our minutes, and I think we'll probably wrap up a little bit early, but I'm curious from the group as a whole, when you're in that moment of uncertainty, where there's not a clear answer yet, and you have to kind of wait and see, what tools do you draw on to get through that? So I'll throw that out to you guys. We've still got Laura and Bill out there. What do you do what are your suggestions or your strategies for dealing with uncertainty in these cases?
Sometimes it's just waiting, and it's not easy for us to wait. We sometimes feel like we want to or have to somehow push that along, and sometimes I think it's difficult when we understand we may need to wait on this. One side note I did have, and I've had situations here where this has happened. It was interesting to me to hear that he wants to achieve getting a CDL, and boy, the regs around CDLs are really, really tight around substance use, and this could actually, I think, negate that until he has this straightened out, because we've had individuals who made applications to CDL, and they were actually referred to us and had to complete an entire treatment program before they could even be considered to get into their training program for CDL. So that's just kind of a futuristic thing, as you were kind of talking about that. I know it really isn't germane to what we're talking about right now, but really I think we have to wait for this to evolve a little bit, because his goal is to get over on this and to providing samples. There aren't really samples, etc. So I think it may be, someone's going to need documentation that he successfully completed something. And at that point in time, it may catch up with them.
Right. So part of the way that this relates to the other question is just knowing that it's going to catch up with him, and that this is part of his learning, right?
Yes.
And so I'm curious about what kind of self-talk you use to kind of get yourself through that. But part of it sounds like it's just instrumental stuff of, well, we know that it's not over yet, so we just wait till he comes back, and he'll come back in a little bit worse shape than he's in right now.
Yeah. No, I mean, he hasn't disengaged. Like I said, he reached out to cancel the group because he doesn't want to be discharged. He knows he needs it for someone or something in the near future that he completed. So he wants to make sure that if someone calls and he's like, hey, is he still? Oh yeah, he reached out. He told us. Just that is enough. What's going to end up happening is just the fact that he realizes that it's not going to be that easy to get over, because his behavior patterns are really common.
Yeah.
He's just not used to them being spotted outside of our facility or just the field of drug and alcohol. We see him every day. Right. His job probably does not. So we can see right through what he's doing. We know exactly what he's doing. We're very aware of what's going to end up happening, really. It's just like, okay, here you are. Right. Now here's your group schedule again, and we expect to see you at every single group. But it's just hopefully, like, you know, like you mentioned before, it's what is our obligation as far as his employer kind of buying into everything that he presents. And, you know, maybe not necessarily reaching EAP if we don't have a release, but I believe we do have one for the boss, you know, at his job anyway, because I think he needed to sign that because that's who he stated was referring him, even though we didn't receive a referral from them. So I believe we do have a referral for someone there that we can contact.
Laura, what do you do with uncertainty?
Okay, I'm not muted, right? Okay, I'm good.
You're right, we hear you.
Okay, perfect. So I'm pretty good at this. I'm taking a class, and one of the questions was, how good are you at ambiguity and waiting and uncertainty? And I think it's so hard in today's day and age when everyone texts and they need a quick answer and you have to respond constantly on the spot. But I think sometimes sleeping on things, mulling it over, answers could come to you in the shower. You know what I mean? Like, I'm pretty good at stepping back from a situation. It sounds like with this one, things will play out. There will be consequences at some point, like Yamelisa said. There's going to be that, where's your final paper that says you could come back, or something's going to kick this into action. And in the meantime, you kind of step back and wait, as Bill said. Sometimes you can only wait in so many situations in life. And I think in today's society and world, we don't like that. And it's really hard for us. We want quick answers. What's your answer? Tell me now. And that's just not, I think, where we are in this world, and especially with this case. So I would be okay with waiting it and seeing what happens and just being there. When the pieces fall, the consequences hit. Just being there for him, that he's ready to pick up and go on.
Thank you.
Chris, what do you do with uncertainty? Got some strategies?
You heard it before, kind of sitting back. I kind of give things a little bit of time, just give a break from it, and then readdress it in the future, maybe just with some fresh energy. Obviously, we're here at ECHO, sounding off on other individuals, see what they have to say. Yeah, those are some things that I do.
Great. Jazz, what's your go-to?
I myself am one, like, I am one to act immediately, and I have come to notice that. So I think just actively, like, reminding myself, like, hey, this is what has happened in the past, and just like act on things that you want an immediate answer. Just like Laura explained, that we all like crave that, we need that. So just to sit back and to just kind of process things in my head, and then process and bring in others to kind of talk things over, because that makes it easier to kind of center yourself and to make better decisions that way.
Yep.
Well, more well-informed decisions too, once we learn more about what exactly you're dealing with.
I love practicing breathing exercises with my patients, because then I get to do them too.
Now let's take a deep breath together. Right?
Okay, we're going to start with the belly. Yeah, so that's one that helps me. But my other mantra that I like to use for situations like this is, it sounds stupid, but it works for me, is it's all information. So just sort of, that's my way of taking a step back, is that there's just so much information in what he's doing. Yeah, all information, right? And I really wonder, I guess the other part is getting a little curiosity about what happens next, right? Yeah. It's all information, and what's it going to be like for him to be so seen, so visible, that right? I mean, when you were talking about the urines, I was thinking about some of our favorite people. That these things evolve over a long period of time. Our urine cups probably have a little more information on them than yours do, so they'll show us that it's not in the right temperature range, and that it doesn't have enough creatinine in it, or whatever, that it's not pee, right? And those are really interesting conversations with people. It's like, this is not urine. Like, look, I can show you this isn't urine. So I'm going to need you to go to the bathroom and get me another one right now. Here's some water.
If we're still in storms, we can send it out and get it more.
Yeah, but I think that it, sometimes those conversations are such interesting ones, because I can say, look, I know that it feels scary to give a urine that probably has some stuff in it that you're not sure what I'm going to do with that. But I have the luxury as a primary care office. It's a little different for you. So, but you know, I have the luxury of saying, for me, if there's something in there, it's better for me to know, because I don't have a role in doing any kind of punishment for you. Right. So it's all information. For me in that case means, oh, this person is worried that I'm going to punish them. That's why they're giving me a fake urine. So those are great conversations that we get to have, that maybe deepens our understanding a little bit more about what is treatment actually about, that it's not about being in trouble, even though he is in trouble, that it's about being well. And how do you help someone sort of make that transition from trying to hide things and the shame that's involved in the addiction to being more open and trying to face what are the consequences of what you're doing.
Yeah, and we already heard it, you know, a little bit of time involved. It's like, you know, you said you'd give me a letter and I can't go back to work without that letter. Therefore, like, you are responsible for me being out of work. So, like, no.
Yeah.
Not really.
Yeah.
We're not.
Yeah.
But I think also the benefit is that, you know, at Mars, in the Hispanic track anyway, that's, you know, the track that I can speak on behalf of, we have a team approach. And he's already attempted the, you know, divide and conquer. It's like, oh, well, I'll ask the group provider to give me the letter. Oh, I'll ask the individual counselor to give me, I'll ask the orientation. And we're all like, no, that's not how it works. You know, we need to see your progress to be able to provide you a letter. And there's a conversation that's going to happen between all of us. Yeah. Before anything is put on paper. So that's, part of it.
And that's another way of dealing with uncertainty, is having a team that functions and has a unified message and can help contain someone a little bit till they're ready, right? Cool. All right, so if we wanted to do a little closing, what's a nugget that you're going to take with you today? So I'll give you half a second to think about that, and we'll do that as a closing and then sign out. A nugget of something that you're going to take away with you today. You want to start out there, Zoom people? Bill or Laura?
Okay, I'm not mute. So my nugget to take away is I'm going to better understand our Hep C procedure and process by getting you the information from Melissa. She's the expert in that area, but it really piqued my interest going back to the beginning slides, and the it was fascinating talking about the cases, but I really liked the data in the beginning. So that's something I'm going to learn more about, as how our patients are coming in and, you know, the latest practices with them.
Great.
I agree. I thought the presentation was really important, both on the Hep C as well as the co-occurring. I mean, there's so many of our patients that are coming into treatment right now with co-occurring disorders, and I just think some of the highlights on that and some of the information on that, it's really good to reflect back on that and have that observation about what's effective and not effective, and in working with psychiatry and in working with other mental health providers to really make sure it's as seamless as it can possibly be. Because unless both of those sides of the equation are balanced, it's just very hard for the patient to make any kind of significant progress.
And then we'll zoom in here. Yeah, Melissa, nugget.
For me, definitely just hearing from the stance of a PCP or a psychiatrist, knowing that there are actual steps that get followed when addressing co-occurring disorders, because our clients basically come in desperate, like, I'm a guinea pig, and they keep throwing different medications at me, and we have to explain to them there's a purpose, but I didn't really know. I just I figured I was on your team, I defend you. But yes, there's we start with this, and then we move on to SSRIs, and then like as you move through, it's depending on what their needs are, and you'll stop when you find the right one. So that's great to know.
For myself, for someone who will particularly be working with Hep C population, I guess, to understand the work that we still need to do, and getting them from, okay, not knowing to, okay, I'm knowing I'm diagnosed, but let's get you to treatment. And the work that we need to do to get them there.
I'm going to give a couple of resources out in Easton too, so I'm definitely going to, not just for this specific individual, but to use it for other individuals that we've got in contact with through our office, and definitely going to push over to them and let them know. Hopefully we can get something started for this individual.
Great. I think my nugget has to do with proactively communicating, collaborating with the psychiatrists out there. It's a challenge and sometimes a barrier that I kind of accept as being there, even though it's one that I've probably by my own lack of proactive conversation contributed to that barrier. So taking a good look at that and thinking about when to try and have a face-to-face or at least phone-to-phone conversation with the psychiatrist to clarify some goals of care. Great. Awesome. Okay, awesome people. Small but sturdy crew at the end here. Our next ECHO is in 2 weeks on the 28th. Please, 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 there's a link in the chat, but also in the email announcement about a survey to fill out. We get to send those back to New Mexico so they know whether we're having an impact at all. So please fill out a survey, and we'll see you in 2 weeks. If you've got a case, Jasmine will help you get it ready. We'd love to hear what's going on out in your organizations as well.
Elections are next Tuesday.
Don't forget to vote. Yeah.
The next one is 2 years, right? Part 1 and Part 2?
Possibly. Yeah. Okay, great. See you in 2 weeks.
Rally in the Valley.
Bye. Rally in the Valley. Woo, yeah, that's right. Rally in the Valley. Go, go, go.
May 19th. Bye-bye.
Bye. Yes. Most of the events will happen here. Yeah, at Arts West.
Bye-bye.
Awesome.
Next week, May 19th.
Totally
I was like, oh yeah, Ron's going to be here this year, and I thought, like, that would be nice.